Welcome to Third Rock Ultrasound. Since 1998, Third Rock Ultrasound has presented educational programs to help clinicians integrate ultrasound technology into their patient care, with thousands of courses teaching thousands of healthcare professionals at worldwide locations. This is Module 5B, Biliary Pathology.
Now it's time to talk about another pathology. What do you think?
Biliary pathology, good stuff.
Biliary pathology, that's dealing with the gallbladder kind of area. So biliary pathology, so let's think about that. Let's give them a couple tips.
Sure.
I'll start off. I think one of the great things about biliary pathology is it's pretty easy as well to find things. You can scan through, you're looking through the liver. The liver's the best window in the body, so you're gonna find some things pretty quickly. So that's kind of fun and easy to start off with. What do you think?
Yeah, there's the problem though that there's a lot of subtleties to scan the biliary system, and you can miss stuff pretty easy unless you really start to practice a lot and get some experience. So you want to make sure that you back up your findings when you start doing biliary ultrasound until you get more comfortable, more confident with what you're finding.
I think that's those are two great points. So without further ado, let's get started.
The objectives for this module are the ultrasound techniques for evaluating cholelithiasis and cholecystitis. Cholelithiasis is a very common problem affecting 10% of the general population. Although most stones are clinically silent, up to 25% of cases can develop pathologic complications. Risk factors for gallstones include female gender, advanced age, gastric bypass surgery patients, and patients with hemolytic disorders. There are 3 ultrasound criteria for identifying gallstones by ultrasound. They are echogenic, have acoustic shadowing, and have gravitational dependency. Although gallstones will create an acoustic shadow when imaged by ultrasound, not all stones will demonstrate this finding. Here we see a typical case of cholelithiasis. You can see the stones within the gallbladder are echogenic, create acoustic shadows, and are located in the dependent area of the bladder. Here is another case using a longitudinal view of the gallbladder showing gallstones with acoustic shadowing. This is a transverse view of the gallbladder showing gallstones with acoustic shadowing. This video shows a longitudinal view of the gallbladder with multiple small gallstones that do not create acoustic shadows. This is the portal vein, and this is the inferior vena cava. In this case, there are many gallstones that appear like gravel laying on the most dependent wall of the gallbladder. Together they cause a wide acoustic shadow to be formed. This is a transverse view of the same case as the previous slide. Here we see one relatively large gallstone in the neck of the gallbladder. It is sometimes difficult to see stones in this position, but in this case it is made easier by the prominent acoustic shadow. This video demonstrates a finding that is often missed by the novice ultrasonographer. It is called wall echo sign. Here the gallbladder is full of gallstones. Therefore, the examiner can only see the most superficial wall of the bladder and the stones located immediately beneath this to create a wide prominent shadow. However, the examiner cannot see the entire bladder since the ultrasound signals are blocked from reaching the lumen and deep wall. Here is another case of wall echo sign. This is the superficial wall of the gallbladder. Immediately adjacent to this wall are many gallstones that completely fill the bladder. Here is the wide acoustic shadow created by all these gallstones. This is another case of wall echo sign in the transverse plane. Cholecystitis is inflammation of the gallbladder. This is usually caused by obstruction of the common bile duct, and therefore the presence of gallstones is the #1 risk factor for development of this problem. Inflammation is created by increasing pressure caused by the obstruction of flow of bile into the gastrointestinal tract. The bladder often becomes secondarily infected. Acalculous cholecystitis is a rare condition mostly seen in critically ill patients. It is thought to be due to the stasis of bile as a complication of some other serious process in the body. Acalculous cholecystitis represents only 1% of all cases of cholecystitis. The signs and symptoms of cholecystitis include fever and chills, right upper quadrant abdominal pain, leukocytosis, and Murphy's sign. However, reliance on making the diagnosis of this disease by these indicators alone may cause the examiner to miss the diagnosis in anywhere from 20 to 50% of cases. This slide lists some of the complications of cholecystitis. Clearly missing the diagnosis can have serious consequences. The sonographic findings of cholecystitis include cholelithiasis, gallbladder wall thickening, ultrasonic Murphy sign, and pericholecystic fluid. The gallbladder wall should be measured at the interface of the anterior wall of the bladder and the liver. This region gives the clearest resolution of the actual thickness of the wall without distorting effects of posterior acoustic enhancement caused by the anechoic bile. In general, a width of greater than 3.5 millimeters is considered to be abnormal. This transverse view of the gallbladder shows dramatic thickening of the gallbladder wall. This transverse view of the gallbladder demonstrates a very large stone lodged in the neck of the gallbladder. The stone measures greater than 2 centimeters, and the wall of the bladder is clearly inflamed and thickened. This is an excellent case of gallbladder wall thickening in cholecystitis. You have to look very carefully to see the small, non-shadowing gallstones located here. This is a transverse view of the gallbladder from the same patient as the previous slide. Pericholecystic fluid is caused by a weeping of serous fluid from the inflamed gallbladder wall. In this longitudinal view of the gallbladder, a rim of anechoic fluid can be seen surrounding the bladder. Next, we will discuss the ultrasonic findings associated with biliary duct obstruction. The gallbladder drains into the cystic duct to join the hepatic duct to form the common bile duct. The common bile duct is one of the components of the portal triad. The other two structures are the portal vein and the common hepatic artery. To complete an exam of the biliary system by ultrasound, the examiner must obtain a view of the portal triad to look for obstruction of the common bile duct. Typically, the common bile duct is approximately 5 millimeters in diameter. A diameter of greater than or equal to 1 centimeter is indicative of obstruction. When you see an enlarged common bile duct, it is important to keep the following 2 points in mind. If the patient has had a cholecystectomy, then the common bile duct usually becomes a default reservoir for bile and subsequently enlarges. Also, as people age, their common bile duct enlarges usually at a rate of 1 millimeter in diameter for each decade of life. Here's a longitudinal view of the portal vein and common bile duct. Notice how the common bile duct is parallel and anterior to the portal vein. In this image, we see the portal triad, but the common bile duct is enlarged to the point where it has a greater diameter than the portal vein. In addition, a gallstone can be seen lodged in the common bile duct. In this video, we can see stones lodged in the cystic duct that drains the gallbladder into the common bile duct. This is the gallbladder. It is folded over on itself and very close to the skin surface. This is the portal vein. Here is the inferior vena cava, and here we see the enlarged common bile duct. There are stones located in the duct, and these stones create acoustic shadows. This video is from the same patient with color flow applied. You can see pulsating flow in the hepatic artery as well as venous flow in the portal vein. Here is another case of imaging of an enlarged bile duct with the help of color flow. You can see the flow through the inferior vena cava located here, and the portal vein located here. The enlarged common bile duct, however, does not demonstrate flow. Gallbladder sludge is a very common finding on ultrasound exams of the biliary system. The ultrasonic characteristics of sludge include a low amplitude intraluminal echo that exhibits gravitational dependency. This is a longitudinal view of the gallbladder in a fairly typical case of biliary sludge. Here is another case of biliary sludge. You can see the sludge laying along the floor of the gallbladder. In this case, sludge is easily seen near the neck of the gallbladder, but the walls of the gallbladder are also thickened from inflammation, so this patient has cholecystitis. So what should the clinician do with gallbladder sludge? It depends on whether or not the patient is having symptoms or findings associated with cholecystitis. If asymptomatic, just watch. Let's take the information we have reviewed and put them into a clinical strategy for taking care of your patients. If a patient presents with the signs and symptoms of biliary disease, then an ultrasound should be performed to look for evidence of stones. If stones are found, then the examiner should look for evidence of bladder inflammation such as wall thickening and/or pericholecystic fluid. If inflammation is present, then immediate surgical consult and/or admission should be pursued. If the patient has cholelithiasis, but the examiner does not see signs of inflammation, the patient should be treated for pain and nausea, and the examiner should consider another imaging study through radiology. If the final determination is that the patient does not have cholecystitis, but does have gallstones, then outpatient follow-up should be arranged with a surgeon, provided the patient's symptoms can be relieved. If the bedside ultrasound of a patient thought to have biliary disease does not show evidence of gallstones or inflammation, then the patient should be evaluated for other causes of right upper quadrant pain. An additional imaging study through radiology should be considered based on the quality of the images and experience of the clinical sonographer that performed the bedside study. Here are a few clinical pearls for biliary ultrasound. Any pathology that results in generalized edema has the potential to result in edema of the gallbladder wall. In this video of a patient with ascites, the gallbladder wall is very thick from edema. This is sometimes difficult to differentiate from a bladder with an inflammatory process. Occasionally, an examiner will encounter gallbladder polyps. These structures have the following characteristics. They are adherent to the gallbladder wall, they do not move with changes in the patient's position, and they do not create acoustic shadows. It is important to know these characteristics since gallbladder cancer should be in the differential if such a mass is seen on biliary scanning. This video is from a patient who presents with jaundice and a non-tender abdomen. Notice that the gallbladder is enlarged and that echogenic material in the bladder is immobile. This is gallbladder cancer. It is a rare malignancy that is difficult to diagnose until its advanced stages due to a lack of symptoms. Development of this cancer is correlated with the presence of gallstones, and it has a very poor prognosis.
That's biliary pathology. So a couple final points here. We started with two. Let's finish with two. So I'll start off with that. I think my final pointer for you is practice, practice, practice. With biliary pathology, again, it's easy to find things early on, but it takes a lot of practice to get good enough to be comfortable making these diagnoses.
Yeah, and with that in mind, when you're starting out with biliary ultrasound, be a little humble. Find some stuff. Yeah, it's really exciting to find gallstones, and it's really cool to find pathology in your patient. But make sure that you back up a lot of your studies in the beginning with something through radiology or another person who has more experience at doing this type of thing until you get a comfort level, a confidence level where you can make your own interpretations without getting another study or somebody else to look at it.